John's Policy Officer, Older People's Mental Health Policy Unit at the Mental Health Branch of the New South Wales Ministry of Health. And Kate Jackson's the Director of Older Persons Mental Health Policy Unit, again with New South Wales Ministry for Mental Health. So welcome, guys. You're on the clock.
I'm on the clock already.
Wow, my time starts now.
All right. I hope it doesn't explode when we get to the end. So, hi everyone, my name's John Stevens. I'm a Senior Policy Officer with the New South Wales Ministry of Health, and this is Dr. Kate Jackson, and she's the Director for our team as well. So what we actually did was we actually developed a statewide project to bring about sustainable change around the physical health outcomes for older people with a mental illness in New South Wales. We wanted to cover both inpatient and community services. And interestingly, the genesis of this project, Kate and I were just discussing, happened at the very first Equally Well Forum Symposium, which was in Melbourne, I think, in 2019. Correct me if I'm wrong, Russell. So just as a bit of background, there was a bit of a policy impetus, obviously, at the time, and still is, both with New South Wales Health's commitment to the Equally Well Consensus Statement, but also the life expectancy gap that we've seen and we've talked about this morning, which is still quite a tragic thing to think about. The time was definitely right for us to make some difference. We also saw within our clinical benchmarking work that our clinicians were interested in making changes in this area. So the stars basically aligned. We then developed what we would call an expert reference group and a project team. We started thinking about what can we do to make a difference? How can we make a difference? We had previously done another project around improving recovery-oriented practice in New South Wales, and we were pretty successful in actually getting all of our services in the state for older people's mental health to change their practice. So we thought, let's try again, but let's try and improve the physical health outcomes of older people. So what we did. The project was designed as a collaborative process from the genesis. So we brought together not just the top tier experts, we brought in peer workers, we brought in NGO partners and academics. We did a literature review, we worked out where the gaps actually were in the implementation science and started thinking of what could be done to actually create change, not just to that we were just having a bit of a joke at the table. There were the thinkers and the doers, and they don't always align. We had to make them align. So we used the CEC, the Clinical Excellence Commission, has what's called a PDSA cycle, which is a plan, do, act, study and act. And that cycle, basically, you keep going around and around until you achieve your goal. So we had the mechanisms already built in. We workshopped it with all of our local health districts. We got some experts involved, including Russell came in, spoke, and we started talking to teams about what they could actually do locally. What were their passions? Where were the issues that they could actually work on? So it was agreed that what we would do is, rather than make one big change, we would actually get teams to think about what they could actually do locally. Have I gone through? I've jumped a slide. That's all right. That's all right. So, as you can see, New South Wales, it's a pretty big place, pretty big population. These are the sites across the state where we had both inpatient and community teams that were invested in the project. What we actually got them to do was to think about what they wanted to do locally. So we had 13 units and inpatient and community teams that developed individual projects. Some were in the hospital, some were in community mental health centres, and some of the projects actually went and worked with people in their homes. That allowed us to actually target people where the local need was and where the local resources were. We had policymakers like myself and Kate involved, a lot of frontline clinicians and workers. We had our consumers were involved. Co-design was central to all of the projects. Health managers, academic partners, and CMO partners. Academic and CMO partners are actually a new element of this project, where we actually wanted to to get academics on board so we could actually publish what we found. With the recovery project, the previous version of this, we didn't actually publish our findings other than in a project report, so it wasn't put out there in the peer review literature. What we then moved on to, I've lost track of my time, is we used the Liu et al. WHO framework and we adapted it for our project. That allowed us to actually categorise the types of projects into three broad categories. This then became the foundation for us to actually develop the workshop that I've already mentioned, but also a toolkit resource for our clinicians to really look at what sort of projects they could realistically implement, what was off the shelf that they could take and work with. This also gave us a great platform to actually categorise the work and to keep abreast as to what everyone was doing. Sorry, I have not kept up with my notes. So we basically undertook a simple process that was supported by a project team and an expert reference group. Now, this all looks like a lovely picture. Everything was working wonderfully, and then the COVID lockdowns happened. And if you want to find out the fastest way to derail a large statewide project, have a pandemic. The time frame of the project it was originally going to be 18 months. This was 6 years ago. The capacity of our services to actually participate in the project shifted radically. The clinicians that could be involved were redeployed. One of the key tenets of the model that we've used is that it was adaptable, it was flexible, we were able to pivot. So we sort of went, and I mentioned before, we went from start where you can, but I think what we really did was adapt where you need. I've completely lost track of where I am. That's all right. So what we did was we actually adapted the project. Those LHDs, those services that could no longer continue, we pulled them together and using one of our NGO partners, which is NEMI, the NEMI Health Prompt, we made a multi-site trial out of that project. We did all of this without any funding. The primary resource that we used was people's passion. Some of the local projects, they actually went and got some seed funding, particularly if you need to print publication material. But broadly speaking, this was all done without any funding. And it just goes to show that you don't need a bucket of money to actually bring about change. What you need are people that are passionate about change. And I think what we actually had, it served us really well. We had, everything was set up for us. All we needed to do was to bring the doers and the thinkers together and to make a change. And I'll just pass on to Kate now, who can talk you through what happened.
Thanks, John. Checking you can hear me up the back. All good, thanks. So what were some of the outcomes of this project? And we have reached a conclusion of the project, but things are being sustained and embedded into ongoing practice. And so what this project really has been successful in supporting a range of practice improvement initiatives, totalling 8 projects across 11 local health district older people's mental health services in New South Wales, both metropolitan and rural New South Wales, and also NEMI as a community managed organisation. Many of the projects have now been embedded into ongoing practice in older people's mental health services, so they are being sustained. And some have indeed been taken up within other services. And it was great to hear this morning quite a bit of talk about things like the NEMI Physical Health Prompt, which was a prompt that was involved in a number of our projects. A majority of the projects have been published into peer-reviewed publications or are being progressed towards publication. I think that was one of the benefits of having the partnership with academics, was that they assisted in project design and evaluation ethics approval processes for publication and so on. So that was a key achievement. And we're also looking to publish the outcomes of the overall statewide project. The statewide project report, though, has already been published on our New South Wales Health website, and that was intentional so that we could share the learnings from these projects, whether or not they made it to a peer-reviewed publication. This is about plugging that implementation gap in terms of successful and effective interventions. And so the statewide project report gives some more detail about those 8 local projects, including some of the lessons and outcomes from those projects, as well as the overall statewide project. So hopefully something there for everyone in terms of what are sharing some of the learnings from this project, whether you're at the policy level as we are, or whether you're more at the service level. I think there's probably something there for you. And as I say, one of the main aims of the project had really been about addressing that so-called implementation gap, and I think we have had collectively, because this is very much a collective project, many people involved in this project, so I think we have really collectively made a significant contribution to that. Oops, that's not good. So this is a summary table of the completed projects. Don't worry if you can't see it, because it is in the project report. But there were 8 projects, just to give you a bit of a flavour and whet your appetite. There were 8 projects, and they covered broadly 3 key focus areas. So there were 4 projects that really were about empowering consumers around improving their physical health through physical health prompts, and individualised health coaching and or health promotion type interventions. So that's half the projects were really in that sort of space. There were 2 projects on physical health screening and assessment, one involving metabolic monitoring and one around comprehensive physical health screening and assessment. And there were 2 that were around physical activity and exercise. One of those was rural and one was metro. So a range of settings, range of kinds of projects, but there were some themes there. And those projects then really covered those 3 domains of the WHO implementation framework that John mentioned earlier. So there was a span of that. But that's just to whet your appetite, so have a look at the project report. And so what was successful and what did we learn from the project? Well, we found that creating the right environment and processes to support practice improvement was really important. So some of those key elements, and John talked about a few of those earlier, one was around the distributed leadership approach. Not just leadership at the policy level, leadership at every level of the project. And that was really important, harnessing that passion and using it to provide leadership for the project. We did have some mechanisms. We had a statewide project team and a statewide steering group that kept advising on the project throughout. We had some communication and management strategies, engagement strategies, and they were important. And ongoing commitment and persistence, along with that flexibility to adapt in the face of changes and disruptions. And as you've heard, we had a pretty significant disruption in the COVID pandemic through this project. And so I think that point of that ongoing commitment and persistence and ability to adapt has been really important. As you've heard, this was intended to be an 18-month project. That was probably always ambitious, but it did take five years really to conclude this project, and people stuck in there by and large for the duration. The start where you can approach, so this, John touched on this, but I think this was really important. We asked people to identify somewhere they could start. Didn't have to be a big project, and as you've heard, we adapted so that we kept people on board in the project through the multi-site trial of the NEMI physical health prompt. But that start where you can approach really enabled action, and it enabled adaptation. And also, it has been important in terms of sustainability of the project. So some of those projects that seemed like a fairly small thing, nevertheless have been sustained and are making a difference in an ongoing way. In terms of new collaborations and partnerships, and again, John mentioned this, but our community managed organisation collaborations, particularly the collaboration with NEMI, really supported greater local health district participation in the face of capacity challenges associated with the pandemic in particular. And our research collaboration, as I've mentioned, it did add complexity, because the more partners that you have, the more complex in some ways things are. But it also ultimately added rigour to project design and evaluation, and it certainly increased publication. And in terms of our efforts in involving people with lived experience, this was variable across the different projects, from some which really had true co-design to others that were more around consultation. But I think the fact that 4 of the projects really did focus on empowering consumers around their own physical health was a positive in that sense. And I think we know that one of the challenges for improving physical health outcomes for people with mental illness is the complexity of the health system. And we've heard a lot about that today. And I think this project did find some ways through that complexity, and part of that was through relationships and partnerships. And so what did different people bring to the project, and what made it work? Well, the policymakers, that's us, we used our policy platform and commitment to Equally Well. We had existing collaborative mechanisms, and we also used our policy role to establish project support, come up with a project plan, and then we really supported others who made it happen. Again, that ideas and action combination. Health managers, that might be some of you, really drove support for the projects locally and provided leadership for frontline staff in developing and adapting and implementing projects. Our older consumers provided lived experience input to project development and actively engaged with these projects. These projects were really well received on the ground. Sorry, move to the next slide. Frontline clinicians and peer workers, and there were many peer workers involved in many of the projects. They co-designed local projects, and they were really the key people doing the work of implementing projects and sticking in there when things changed and capacity was constrained. Our academic partners brought expertise in research design, evaluation and publication, and as I've mentioned, also in finding a path through ethics approval processes. And our community managed organisation partners brought some existing or adapted physical health tools from their organisations and openly shared those with us and collaborated on projects with older people's mental health services. So, final slide. This project has been quite a journey. It commenced just before the COVID pandemic. As John said, we were talking about it at the first Equally Well symposium in 2019 in Melbourne, and we've presented along the way. But I recognise that some people here may have heard some things about this project before, and others perhaps hearing about it for the first time. So hopefully that gives you a bit of a sense of the kind of approach that has been taken and some of the outcomes from that. And I hope that you'll have a look at our project report. Did I mention that already, the project report? And find something to help you in your part in progressing the aims of Equally Well. And happy to have some questions if we've got time. Yeah.
There's a mic over there, and also I just forgot to mention before is don't forget the WhatsApp if you've got any questions, because Russell's going to keep an eye on those questions as well. But if you, I don't know if you can take that mic down. Has anyone got any questions? Yeah, there's one up here. I don't know if I can take, if that mic can help to stand or not.
On the local level, who's responsible then to follow up on any knowledge or tracking that? Is it our medical guys or is it GP?
So there were a range of projects, and so some of them were about a number of them. So take for instance the near my physical health prompt implementation was about having those conversations, those guided conversations around a range of potential physical health issues, and the clinicians encouraging the consumer to follow up with the GP. We did get some paired results from that, so some of that's in the project report where there was follow-up to see whether, what actions have been taken as a result of those initial conversations. So yes, in some instances there was feedback about what follow-up had occurred, and I agree that is one of the challenges. Don't just screen, intervene, and also provide pathways to other services and see whether some of that is being acted on. So definitely, some feedback around that. Some of the projects like the metabolic monitoring was definitely embedded into ongoing practice, including the monitoring aspect of that. So seeing what changes are occurring as a result of the intervention from the service. So probably a range of things. John, did you have any other comments on it?
I was actually thinking of giving you a case example. With one of the projects, a number of people were identified as having unscreened cancers. Now, those patients actually went on to receive treatment, and as part of our evaluation of the whole project, we actually kept an eye on that. Now, most of those people are now in remission, and these people that would otherwise not have been screened, let alone intervened. So we actually built evaluation and monitoring of the projects into the design of the broader statewide project.
Any more questions?
Yeah, I've got one.
Yeah, go for it.
With the outcomes of the project, like you had the system level 1 and the individual one, did you measure changes in staff attitudes? Or impact?
Yes, to an extent. So we've got some qualitative evaluation of the overall project, and that was part of the partnership with Charles Uni. So we do have some qualitative feedback from people involved at the project at all different levels about the success of the project, and some of the barriers, some of the enablers in terms of implementation. So, and that's what we're hoping to publish. But some of that's also in the project report. But it's qualitative feedback. Yeah.